Welcome to the Sened podcast, where healing means justice and care demands courage. Sened is the solidarity network of doctors and healthcare workers born from the urgent need to stand with those repressed for speaking out against the ongoing genocide in Gaza. We believe that healthcare work is movement work, and that resisting systematic and structural violence is a duty for us all. This isn't just a podcast. It's a tool of resistance, a place for collective learning, political clarity, and unapologetic solidarity. Together, we'll break down how the healthcare system is used to uphold systematic violence, and we'll share tools, analysis, and community to help you resist it with courage and conviction. Welcome to Sened.
Welcome, you guys, to the second session. This will be Legacies of Violence in U.S. Healthcare and Why We Must Disrupt. So today's session is really an opportunity for us to take a step back and think critically about the repression that we've experienced. It can tell us about our position as healthcare workers in relation to larger systems of violence that we see operating around us. This session is kind of an invitation to understand the genocide and the subsequent repression of healthcare workers' advocacy, not as a departure from a system that's otherwise working as it should, but as an exceptionally clear example of the ways in which healthcare institutions participate in larger structures of violence and the role that we play as healthcare workers, and how we understand these same structures of violence that we're witnessing to be the same ones that produce disparities in health outcomes that we encounter as providers in the clinic in the form of differential vulnerability among our patients to disease and injury. So many of the healthcare workers that we see standing up against the genocide and speaking out against the genocide are the same ones who have long recognized the connections between the injustices that we witness daily in our hospitals and clinics and the larger social systems that produce them. Today, we're drawing on this collective wisdom and these ways of thinking about violence and structures of care in the clinic and in medicine in order to think about what is unique about our position as healthcare workers that allows us to kind of see these connections so clearly, and how this position provides us an opportunity to name and resist these particular structures of violence that, again, render some populations disproportionately vulnerable to early death, injury, and disease, whether we're talking about Palestinians in Gaza, whether we're talking about undocumented patients at the border, or people of color across the US. How do we kind of understand the role of medicine in upholding systems of violence in ways that directly impact our patients' health, and our role and our possibility and potential to intervene as healthcare workers? So in October 2024, Dr. Firoz Sidwa published a piece in the New York Times which described patterns of injury that were witnessed by himself and 65 healthcare workers who had worked in Gaza over the last year. In this piece and in subsequent interviews, Dr. Sidwa, he harnesses the full weight of his authority as a physician to make an argument that should appear painfully obvious even to non-healthcare workers or non-medical people in the audience, that this is not a pattern of injury that occurs by accident. His essay generated an immediate wave of backlash and repression that sought to discredit Dr. Firoz and the other 65 authors. So one of the things that I've thought about a lot over the last 18 months as we've witnessed the various forms of repression that are directed against students and healthcare workers who are speaking out against the genocide and taking activist and advocacy stances in solidarity with the people of Palestine is, what do these instances of repression, these instances of backlash, what can they tell us? What can we learn by thinking about them from kind of a critical standpoint? So when our actions trigger intense repression in response, it can sometimes be a sign that we're doing something very right. So why is it that Dr. Sidwa's words and his article provoked such vehement attempts to silence and discredit him and 65 other healthcare workers? I would argue that It is in part because, as healthcare workers, our voices carry a particular kind of legitimacy and authority to speak to larger questions of intention, causality, and responsibility in relation to the wounding and the injury of the human body. So, if we take another example, any good pediatrician can tell you that particular patterns of injury will prompt additional questions about non accidental trauma in young children. For example, an accidental burn will almost never have a uniform thickness. As the child withdraws their arm or their leg from the painful stimulus, you'll have the most severe burn distally and less severe as you come more proximal to the core of the body, right? When we think about how injuries take place and what we know as physicians about the human body, we know that certain patterns of injury will prompt questions about abuse and can also speak to questions concerning intentionality. So, as healthcare workers, we can notice patterns of disease and injury that prompt us to ask larger questions about their root causes. From these patterns, we can diagnose pathologies that exceed the boundaries of the individual bodies of our patients and identify structures that sicken society as a whole. We can notice, for example, how often our patients with severe asthma exacerbations happen to live within certain zip codes that are disproportionately located along major highways and exposed to the highest rates of air pollution. We can go on to connect this to histories of redlining and contemporary policies that function to effectively uphold structures of residential segregation along racial lines across the US. So, Dr. Abu Sitta has talked a lot about this in the article that was the recommended reading for today. And he talks about how we're able to see these connections between the microstructures that shape our individual patients' health and the macro social structures and policies that kind of tracing the links or the chain that leads to the individual patterns of injury that we witness as healthcare workers in the clinic. And Dr. Ghassan Abu Sitta, he really emphasizes that we have a lot of power because we have this ability to diagnose and kind of observe and make these connections, and to make connections that have the potential to completely contradict and delegitimize political projects of the dominant social classes. He also explicitly talks about how healthcare workers, because of the privilege and authority that our voices carry, we're able to agitate in ways that the system is not necessarily designed to expect or fight back very effectively against. Like how does the agitation and the resistance of healthcare workers against these types of violence in clinical settings, how does it sort of throw the system off? How is it something unexpected that can be a real source of resistance against these multiple forms of violence we see operating in the clinic? So, one of the main things we're going to be talking about today is how our position, not only in terms of our advocacy on Palestine, but as healthcare workers, how it allows us to make these particular kinds of critiques, and what is our larger role as advocates in clinical spaces. And one of the things that we wanted to emphasize today is thinking about, in terms of the genocide and our advocacy on Palestine, how we can connect repression to the genocide as it's operating thousands of miles away, right? Like, how do we extricate these links? It's not just like individual instances of repression or universities punishing students who are in advocacy with Palestine, but how do we make these connections and try to understand it as a singular apparatus that's functioning as a whole? So one of the things that has come out of Dr. Ghassan Abu Sitta's groundbreaking work on the genocide enablement apparatus is this report that was submitted to the UN that directly connects repression of healthcare workers and the silencing of healthcare workers here in the US to the perpetuation and the carrying out and implementation of genocide in the West Bank and Gaza. So, how do we understand the ways in which our silencing as healthcare workers here, repression, disciplinary measures, how this connects to larger structures, right? Like when we think about legislation to make the IHRA definition of anti-Semitism something legal that colleges or universities or medical schools or healthcare institutions and hospitals have to abide by. Who are the organizations who are sort of pushing for particular definitions that classify all criticism of the state of Israel as a form of anti-Semitism? How do we understand the laws and the policies, things like professionalism, that are used to discipline in silence as connected to these larger structures that, when we trace them back and we look at what's taking place on the ground in Gaza or in Palestine, how do we understand this as sort of a larger system that's operating to create the conditions in which a genocide is enabled? So this is how we understand organizations like the AMA hospitals, medical journals, how we understand them as operating to create particular conditions in which not only can a genocide be carried out with impunity, but in fact is enabled by these various kind of institutions that we have to uphold particular projects of Zionism and violence in Palestine.
Thank you, Professor Morgan, for that. So, I'm going to be talking briefly about the legacies of violence in Western healthcare. And I'm going to take it sort of back to an overarching understanding of colonialism. So, I drew this graph when we were researching our book, Inflamed, to really trace out the dynamics of colonialism, capitalism, the economic structure of capitalism, as well as the worldview of colonialism, the way of thinking about the world that is required in order to extract and exploit to keep this economic system going. This graph really kind of breaks down for me, and there's so many kinds of supremacisms that we could add on here that we didn't add, but this is just a little bit like a touch of what you can see. The level of separation, dehumanization, and dominance that's required to uphold the system of capitalism, and specifically to uphold a system of colonialism, to continue the extraction, continue the subjugation, continue a world order in which some people or some beings are not endowed with personhood or are not endowed with rights in order to keep the extraction and the benefits to a privileged class going. And so when you look at this and you look at, at least when we look here at occupied unceded Turtle Island, these dynamics of repression are occurring in every aspect of our society. So these lands were colonized by missionaries, militaries, and medics. Western medicine has always been part of the colonial capitalist project. It was something that was brought to these lands as a way at first to keep the colonizers healthy, but then eventually was given out of the benefit to keep the working class or the extracting labor parties, so the enslaved people, poor working class, indentured people, healthy enough to continue the work of extraction. And if we look at today's policies and also today's outcomes in Western medicine here in the United States and in other colonial contexts, those people who are on the losing order of power have the worst health outcomes. And what we looked at in our book was really tracing how those health outcomes are really driven by damage and the body's response to damage through the chronic inflammatory response. So in medicine, we can see this as white supremacy, but even in India, this is like Hindutva and Hindu supremacy. So every cultural context where the colonial capitalist world order has been instituted will have this sort of casteist dynamics of power. So here in the United States, it is white male cis hetero male supremacy, and those dynamics are actually reinforced through the institutions of medicine. So it's not a surprise that patients who are Indigenous have worse health outcomes in this system, even if they have access to care as they move through the system. They are not treated with the same quality of care or achieve the same health outcomes, not only from how society is designed, but how the very structures of hospitals are designed. So when we look at hospitals in the United States, there's definitely a health and medical apartheid in the United States, but hospitals used to be segregated very officially, and it was the passage of public health programs like Medicare that actually desegregated hospitals where Black and white folks and other folks can be in a mixed environment in the hospital. And that allowed us to study outcomes differently and to really see the health disparities in our faces. As we look at today's administration now removing $880 billion from Medicaid, we're seeing a direct attack on, poor and marginalized people in our society that's going to have an even worse impact on the health disparities that we're seeing. It's important to recognize and remember that medicine has always been a part of the colonial project, and that the health outcomes that we're seeing in the United States are not an accident. They're very much by design. These are the structures. How colonial structures are designed will always damage the Indigenous people the hardest, the Black folks in the U.S. context the hardest. And we saw that in COVID with the health outcomes. The people who died the hardest and fastest were Indigenous folks, followed by Black, Latinx people. And so I think that it's important to recognize when we're looking at those things, not simply to think, okay, well, who has access to care? This isn't just simply an issue of access to care. The history of violence to Indigenous and Black folks, especially Black folks in the United States, is something that cannot be overstated. Medicine has been a a entity, an institute of encoded actual institutional violence against Black people specifically. So modern gynecology was developed through experimentation on Black children, young women, while others watched in the late 1800s. So there were, dozens of women who were experimented on. Often they were enslaved. They often could not give informed consent. And often these experiments happened without anesthesia. And this is how the modern OBGYN field was formed. Everyone should know about the Tuskegee experiments on Black folks, where people with syphilis were enrolled and they were not given proper treatment to sort of track what the natural history of the disease was. So this kind of abuse of the medical system gives, every right for Black folks to be distrusting of the medical system. And when we look at the history of Western medicine, specifically around in the United States, around the Flexner Report, so around the time of the 1910s, when, with the invention of, or the discovery of oil with the Rockefellers and the Carnegies trying to define and redefine Western society through a capitalist lens, it was the use of capitalism to sort of shape the modern university in a way that would continue to benefit the pockets of the peoples like the Rockefellers and the Carnegies with the inventions. But at that time, there was a report that was made that was trying to standardize US medicine based in sort of a German model of science for medicine. So before the 1910s, the US medical system was very diverse. There were lots of offerings from traditional Chinese medicine to osteopathic medicine to herbal medicine to a bunch of different kinds of medicine were incorporated. And after the Flexner Report, that standardization ended up leading to the closure of several medical schools that were specifically focused on training Black physicians, which led to a huge drop off in the number of Black physicians that we have in the United States. I think less than 5% of our medical community now are Black, whereas like over 12% of our population. So it's not representative of the number of people who need to be there. And we know that, Black physicians have better health outcomes with Black patients, that racial concordance actually matters, especially when it comes to things like newborn care. So in terms of this extraction and innovation, this actually continues in communities today. So from Grady Hospital with Dr. Otis Brawley, who was documenting exploitation of poor people, to UCSF's, the infamous Howard Maybach, who was injecting and exposing at least 2,600 Black and brown incarcerated people who were imprisoned without informed consent with toxic chemicals like organophosphate pesticides to see their renal excretion. These experiments have been continuing up until the 60s and 70s that we know of. So this is highly disturbing, especially the one with Howard Maybach, which I followed very closely, because this was after the Nuremberg trials. This was after the doctors' trials. This was after we developed the protocols and processes of institutional review board. So those things existed. And Howard Maybach and Bill Epstein and Albert Kligman, as documented in this book, Acres of Skin, were performing these experiments on incarcerated Black people. And when I think about this too, the disturbing report that just came out in The Guardian by healthcare workers for Palestine was showing the organ theft of Palestinian folks who had died. So bodies were being returned with missing corneas and missing kidneys and other vital organs. So there's this, obviously a physician, a pathologist was probably the person harvesting those organs. So this is a disturbing thing to think about, how medicine today is complicit in the ongoing violence towards oppressed communities. So here are some more examples of how medicine participates in reinforcing settler colonial violence or white supremacist violence in the United States. And it's through the interaction of medicine with these other state entities, such as the police or such as child protective services. One of the hallmarks of coloniality in every context it is found, especially the settler colonial context, is the fragmentation of the family. Our families are what keep us strong. It's what gives us strength. It's what connects connects us to the earth and our place in belonging. And the attack on family seems to be purposeful and systematic, as well as the attack on children. So, when I was at Standing Rock, the elders there were telling us stories. I remember LaDonna told me a story of when they were young, that when the feds would come to the reservation, the parents would strap the children to the dogs and like run them out onto the prairie, so that the children were nowhere to be found when the federal agents would come to the reservation. So they didn't know about the children, because the process of removing children from the home, putting them in boarding schools to, erase the Indian out of the person is something that is a legacy that happened here in California, where there was the genocide of the California Native people. As well as if you go to Ireland, you hear about 127,000 babies that are buried or missing under the Foundling Hospital, which now the St. James Hospital sits on in Dublin. And those are children who were, the families were made intentionally poor by the British settler colonial reality, and the women gave up their children to be cared for in these hospitals. The British caregivers would give these children laudanum or opium, and the kids would die. So 127,000 children. In Canada, we see the same thing with the schools, the residential schools. But medicine is also a part of this project where, Black youth are in restraints or in seclusion more than white youth in the hospital, where we're seeing forced sterilization of Latinx women and detained in ICE, as well as Indigenous women here in California. There was a whole, and also in Lakota territory. So these kinds of situations, in addition to hospitals today complying with the federal erasure of gender affirming care, these kinds of abuses of power are actually structurally built in and baked into the systems of medicine, as well as how those systems interact with other structures of violence in our society, such as child protective services, adult protective services, and carcerality. So this is something very interesting that I just learned about, which was medicine's role in carcerality. So the dynamics in which medicine participates with carcerality and also participates with the police is something that needs to be examined and abolished, because police have no place in a place of healing, especially around people who are being targeted and attacked by the police. Interestingly, with the American Psychiatric Association, this was the first medical association to form. And around the time before emancipation, they were forming these arguments that freedom was actually antithetical to Indigenous and African psychology, which is just whack and nuts. And that after emancipation, insanity became a common clinical diagnosis. Even today, like schizophrenia is diagnosed disproportionately more in Black patients than in white folks. So this is a way in which our ability to even live and exist is being pathologized. Our resistance is pathologized. Our resistance to these systems is also pathologized. People, Black men, were incarcerated upon emancipation, and the medical system was used to promote incarceration of newly, freed Black people from society. The loophole in the 13th Amendment, which allows for labor in incarceration, which is AKA slavery, to continue, is a way in which, okay, you're emancipated, but now you're insane, you're back in the system, and now you're working for free in the prison. This sort of mentality, I think, is what's happening right now in the US as food stamps are cut, housing is cut, healthcare is cut. They want crime to rise as they're building these huge prisons. So if you think about what we need to be doing right now to build really resilient mutual aid networks, because when crime rises, they'll use that as an excuse to come and get our communities. How do we actually start to bolster and take care of each other in a much more effective community-based way to resist what they're trying to do to us? So that is my little briefing on the current situation on medicine and coloniality.
Wow, Rupa, that was an amazing overview. Hi, everyone. I don't think you met me last week. My name is Mesa, and I'll be facilitating this part of the session. So in this section, we will briefly cover the historicity of repressing voices in medicine who speak out against structural violence, and connect these legacies with the continued silencing of healthcare workers that we see today. So what are the dangers of silencing healthcare workers? It's very important to understand the gravity of silencing the voices of healthcare workers who are trying to bring attention to the multiple dimensions of violence and harm against our communities and patients. So what are the stakes for our community members when healthcare workers are silenced, repressed, or terminated for speaking up against harm that impacts our patients? First of all, silencing healthcare workers inhibits our ability to better diagnose the patients. So if we can't talk about the violence that affects particular communities, then we will fail to identify how that violence shows up as death and disease in our patients. For example, without understanding this historical and ongoing legacies of colonialism in the US, we will not be able to identify how the everyday violence of settler colonialism is harming the health of our Indigenous patients and our Black patients. Similarly, silencing the voices of healthcare workers interrupts our ability to treat disease. If we can't speak about the root causes of illness and death in our communities, which are often tied to racism and colonialism, then we cannot adequately treat or protect our patients from further harm, and we can't advocate for their well-being at the same time. In summary, when healthcare workers are silenced, when we use our voices to address and end the structures of violence, our patients and community members die. And that is the gravity of this repression. So we will discuss the repression of Black healthcare workers. On Turtle Island in the US, Black communities were barred from practicing medicine until the late 1800s. James McCoon Smith was the first in 1837. However, most medical schools were preventing prospective Black medical students from applying until the 1960s. For example, Emory University School of Medicine. Dr. Helena Octavia Dickens, an African-American obstetrician and gynecologist, became the first Black woman admitted to the American College of Surgeons in 1950. Throughout her career, she advocated for cancer screenings and sexual health education in Black communities. Her efforts often met with resistance from the predominantly white medical community, leading to professional isolation and limited opportunities. Nevertheless, Dr. Dickens remained steadfast in her commitment to healthcare advocacy, breaking barriers for future generations of Black healthcare professionals. In 1963, Dr. John Holman Jr., an African-American physician, co-founded the Medical Committee for Civil Rights, MCCR, to challenge racial discrimination within the American Medical Association and the broader healthcare system. The MCCR protested against the AMA's tolerance of segregated local chapters and the exclusion of Black physicians from hospital. Their activism led to professional ostracism and threats to their medical careers as the prevailing medical establishment resisted desegregation efforts. Despite these challenges, the MCCR's efforts were instrumental in highlighting and addressing racial disparities in healthcare. The legacy of anti-Black racism characterizing the repression of Black physicians is not a historical legacy, but one that continues to characterize positions in healthcare today. Dr. Aisha Khoury, a primary care doctor who was suspended in 2020 from Kaiser Permanente's medical school after facilitating a conversation about racism in medicine. She was actually recruited as a founding faculty member at the new medical school and was immediately put in suspension after the conversation without a contract renewal. Healthcare workers like Dr. Khoury represent an ongoing struggle for Black physicians and healthcare workers to exist without repression in this system. Our healthcare systems are threatened by healthcare workers who are willing to identify the structural issues in our system to improve conditions for our patients. So the COVID-19 pandemic exposed the failures of our healthcare system on many levels. It showed firsthand that it will push those out of medicine who expose its failures to protect patients. Repression characterized dozens of suspensions and terminations of healthcare workers who tried to warn community members about PPEs, shortages, and hospital failures in COVID-19. Dr. Li Wenyang was a Chinese ophthalmologist who warned his colleagues about early COVID-19 infection in Wuhan. Li was dubbed a whistleblower when he shared that report, and that report was later circulated publicly. Rumors of a deadly SARS outbreak subsequently spread on Chinese social media platforms. So Wuhan police summoned and admonished him and 7 other doctors on the 3rd of January, making false comments on the internet about unconfirmed SARS outbreak. The outbreak was later confirmed not to be SARS, but rather a new coronavirus. SARS, the CoV-2. Lee returned to work and later contracted COVID-19, the disease caused by the virus, from a patient who was not known to be infected. He died from the disease on the 7th of February 2020 at age 34. In 2021, Kanza Barkai publicly drew attention to DMC Sinai Grace's lack of PPE and beds in preparation for the COVID-19 patients who would be inevitably coming through. For publicly exposing this failure in her hospital system to prepare, which would endanger both patients and providers, she was fired from her position as a nurse. DMC Sinai Grace got hit by a wave of COVID-19 patients to the point that the hospital was running out of space for those who were dying. Photos were leaked that showed the remains of people's loved ones stacked in rooms. These incidents of repression in our current times begs the question for us as healthcare workers and students. If our healthcare systems are not meant to protect patients or meant to provide transparency about safety, then what is its purpose?
Thank you for that amazing presentation, Mesa, Rupa, and Morgan. Everything you guys said was so brilliant. Thank you for sharing that. So to end our presentation for session 2 of Cultivating Courage, we're going to be talking about detecting violence in healthcare. In order for us as healthcare workers and students to change the conditions of harm that affect our patients and our communities in the healthcare setting, we have to have the skills and education needed in order to identify violence and harm. Most people can identify the explicit manifestations of violence in the healthcare setting, but the most insidious and dangerous forms of harm and violence are those that are more difficult to identify, but are still parts of and uphold the harmful structures that kill and marginalize our patients. So first, we're going to be talking about the explicit manifestations of violence in healthcare. One of the tools many community members for a long time have used to identify violence is to think about how violence and harm manifest on 3 levels: the structural level, the institutional level, and then the individual or interpersonal level. We can think of structures as the hegemonic cultural values that shape everything in our society. So they include things like capitalism, colonialism, patriarchy, white supremacy, classism and casteism, gender discrimination, and other isms. Now, as healthcare workers and students, we have the unique ability to identify and address how these isms are showing up in the healthcare setting, whether that's the hospital, clinics, medical journals, medical education, etc., and also how they appear in the interpersonal interactions between patients and healthcare providers. By explicit violence, we mean in general harm that's typically easily identifiable as harm against community members or patients. So one of the main structural manifestations of violence that most people can identify in healthcare is the prevention of access to care to particular communities. And this is what we might call conditional care, or only providing care to those who can afford that care or to those who we think deserve it. And this violence is tied to many of these isms. It's tied to capitalism, racism, classism, citizenship status, and all of the isms really, and in some way. Another institutional manifestation of explicit violence in healthcare is the presence of police or other policing agencies such as ICE, Customs and Border Patrol, etc., in the healthcare or hospital setting. The presence of these officers make a very clear statement to our community members and patients that some people are not welcome here, particularly Black and migrant patients. And oftentimes these officers are actually called in to harm, restrain, deport, incarcerate our patients. And this is a very clear manifestation of violence, of harm in the healthcare setting that a lot of healthcare workers are actually working to abolish these agencies from healthcare settings. Another manifestation of violence on the institutional level is the way that pharmaceutical companies experiment, for a lack of a better word, on patients in the global south or on incarcerated patients or on house patients. We talked about some of those examples earlier, but that they take advantage of these marginalized communities to create drugs that they sell to the West that end up not being accessible to the patients that they experimented on in the first place. So some of the manifestations of explicit violence on the interpersonal level can look like medically restraining our patients. which is a form of incarceration and removal of agency, of discharging unhoused patients to the street where they have no shelter or resources. This can look like labeling our patients as non-compliant, which has severe racialized undertones, and it is a punitive measure against patients. This can also look like your peers as a healthcare worker justifying the bombing of hospitals in Gaza, or saying no ceasefire, or there's no innocent people in Gaza, which unfortunately we've seen many, many healthcare workers openly say. This is a clear manifestation of explicit violence on an interpersonal level. But the point we're trying to make here is that even these interpersonal violences are reinforcing the structural hegemony of harm and violence in our society. So on an implicit level, what can and does violence and harm look like in the healthcare setting? So the structures are the same that inform the implicit violence. Like I said earlier, violence is most insidious when it's implicit and difficult to identify as violence. So some of these examples on an institutional level include the fact that many of our hospitals and university systems are built on top of land grants, which are forms of land theft from indigenous communities, while our hospital systems and universities systematically erase and marginalize indigenous people. This is a form of violence that's continuous, it's everyday, and yet it's implicit and invisibilized in society. Some other manifestations of implicit violence is that our healthcare system profits off of disease. So the sicker our patients are, the more money healthcare makes. So the more racism that harms our patients, for example, the more money our healthcare systems make. Similarly, many of our standards of care are racialized. So a great example of this is how pulse oximeters were made to read accurately the oxygenation in white patients. And so during COVID, pulse oximeters actually failed to identify hypoxia in Black patients. This became particularly apparent during COVID, and many Black patients were discharged even when they were hypoxic, when they should have been hospitalized. And so this surely contributed to the disproportionate death of Black people from COVID. This continues to be a problem in medicine and innovation and healthcare. And this is just one example of many. And on an interpersonal level, implicit manifestations of racism and classism in healthcare can look like, for example, which patients healthcare providers touch, meaning which patients you end up holding their hands or sitting at the ends of their beds, and which patients you don't. We see particularly that healthcare workers don't engage in the same warm touch with poor and unhoused patients, for example. This is a form of implicit violence that's informed by racism and classism, and that's how it shows up in the behavior of healthcare workers. Other examples include undertreating pain in Black patients and in women due to racist and gendered ideas of pain, whose pain is real or not. This is also a pretty well-documented phenomenon. So these are just a handful of, unfortunately, so many examples of explicit and implicit manifestations of violence in healthcare on the structural, institutional, and interpersonal levels. When we train ourselves to be able to identify these practices as harm and violence, we begin to better understand our roles as healthcare workers in disrupting those structures that harm our patients as they manifest in the healthcare setting.
Thank you for listening to the Sened podcast. If this conversation moved you, challenged you, or gave you tools to act, share it, organize with it, and build with us. Subscribe wherever you get your podcasts so you never miss an episode, and follow us on Instagram at SANAD.SolidarityNetwork4HCWS. Until next time, from the clinics to the streets, together we resist, together we heal, and together we rise towards liberation.